I'll now be talking about the diagnosis and management of depression. The learning objectives for this lecture are depressive disorders in the DSM-4, symptoms of depression, and management of depression using the biopsychosocial model of care. We will go through an introduction to clinical depression, risk factors for depression, how to diagnose major depression, as well as how to diagnose dysthymia, and finally the management of depression. Depression is a mood disorder. The types of depressive disorders in the DSM-4 include major depressive disorder and dysthymia. Depression causes functional disability and even mortality due to suicides. The annual economic consequences of major depressive disorder have been estimated at $83 billion in the United States. The lifetime prevalence of major depressive disorder in the United States is about 16.5%. Depression is more common in females and the elderly. Major depressive disorder is a chronic condition characterized by remissions and relapses. In addition, patients may have major depressive disorder on a background of dysthymia, also known as double depression. The risk factors for depression can be broadly classified into three categories: biological factors, genetic factors, and psychosocial factors. Biological factors include the neurotransmitters norepinephrine, serotonin, and dopamine. Selective serotonin reuptake inhibitors, for example fluoxetine, serotonin norepinephrine reuptake inhibitors, for example venlafaxine, and norepinephrine dopamine reuptake inhibitors, for example bupropion, have been shown to be effective in treating depression. Family, twin, and adoption studies have also shown that genetic factors too play a part in depression. Psychosocial factors such as life events and environmental stress, as well as personality, also have a role in depression. A major depressive episode may occur as part of major depressive disorder or bipolar disorder. In patients diagnosed with a major depressive episode, it is important to rule out episodes of mania or hypomania in order to distinguish major depressive disorder from bipolar disorder. This is important as antidepressants may cause a patient with bipolar disorder to become manic or hypomanic. To diagnose a major depressive episode, the patient must have at least 5 out of the 9 symptoms listed on the slide. At least one of the 2 cardinal symptoms, that is, the symptoms highlighted in red, must be present. These 5 or more symptoms must be present for at least 2 weeks and should cause clinically significant distress or impairment in social, occupational, or other areas of functioning. These symptoms must not be due to the direct effects of a substance or due to a general medical condition such as hypothyroidism. The symptoms must also not be better accounted for by bereavement. Dysthymia may be distinguished from major depressive disorder in that patients complain that they have always been depressed. Onset tends to be early, in childhood or adolescence. In order to diagnose a patient with dysthymia, the patient must have had depressed mood for most of the day, nearly every day, for at least 2 years. The symptom-free interval in these 2 or more years should not exceed 2 months. Patients should have at least 2 of the symptoms listed in the box. When evaluating a patient for depression, some common differentials should be considered. As mentioned earlier, it is important to distinguish major depressive disorder from bipolar disorder, as the first line of treatment for the former is antidepressants, while the latter is typically treated with mood stabilizers. Another diagnosis to consider is adjustment disorder with depressed mood. Here, the depressed mood occurs in response to a stressor that has occurred within 3 months. Adjustment disorder with depressed mood is diagnosed if the patient does not meet criteria for another Axis 1 disorder. Major depressive episodes may also occur with psychotic features. This can be distinguished from schizoaffective disorder by looking at the time course of the illness. In major depressive episodes with psychotic features, the mood symptoms should start first, and the patient develops mood-congruent psychosis during this episode of depressed mood. In schizoaffective disorder, the psychotic symptoms start first and are more likely to be mood incongruent. It is also important when diagnosing depression to rule out depression due to a general medical condition and substance-induced mood disorder. It is important to rule out hypothyroidism in patients with depression, as it is a cause of depression that is easily treatable with thyroid hormone supplementation. Other investigations may also be carried out to rule out other general medical conditions and substance-induced mood disorder if suspected. Management of all psychiatric illnesses is via the biopsychosocial model. The biological aspect of treatment of major depressive disorder involves medication and, if necessary, electroconvulsive therapy. Major depressive disorder is treated with antidepressants, which may be divided into 4 main groups: SSRIs, which are selective serotonin reuptake inhibitors; TCAs, which are tricyclic acid antidepressants; MAOIs, monoamine oxidase inhibitors; and others. SSRIs are newer than the TCAs and MAOIs and tend to be the first-line treatment because of better side effect profile. The common side effects of SSRIs include sexual dysfunction, gastrointestinal symptoms, headaches, and hyponatremia. TCAs have adverse cardiovascular side effects of QTc prolongation, tachycardia, and hypotension, and can be lethal in overdose. MAOIs have the potential to interact with tyramine-containing foods to cause hypertensive crisis and therefore are seldom used. Electroconvulsive therapy may be used to treat depression when the depression is not responding to medication or when the depression is very severe and the patient is at high risk of committing suicide. Antidepressants have also been found to be helpful in managing dysthymia. Psychological intervention is just as important in managing major depressive disorder. One of the therapy methods commonly used is cognitive behavioral therapy, where a patient is trained to identify and challenge his negative thoughts. Cognitive behavioral therapy is based on the premise that one's thoughts give rise to one's emotions and that decreasing these negative thoughts will decrease the negative emotions. Social management of depression involves psychoeducating the patient's family about the patient's illness so that they can support the patient better. Here is a summary of the main points covered in this lecture. Major depressive disorder is a chronic illness characterized by relapses and remissions. It may occur together with dysthymia, and this is known as double depression. In order to diagnose a major depressive episode, at least 5 out of the 9 symptoms must be present for a period of at least 2 weeks. In addition, at least one of the 2 cardinal features, which are depressed mood and loss of interest, must be present. Always determine if a major depressive episode is part of major depressive disorder or bipolar disorder because the management differs. Depression is managed using the biopsychosocial model of care. Selective serotonin reuptake inhibitors are usually the first-line pharmacological treatment for major depressive disorder.